Hi there, greetings and welcome to another video on surgical discussion. This video is the third of the series in gallbladder and bile ducts, and we'll be discussing about cholecystectomy, which is the one-stop solution for all problems, whether it is an acute inflammation, chronic inflammation, emphysematous gallbladder, gallstones, sludge or whatever. Now cholecystostomy, CVD exploration and Choledochoduodenostomy shall also be discussed. Various tips, important points to keep in mind, and certain pearls of anatomy shall also be presented in the slides. The indication for cholecystectomy is a gallbladder disease. As you know that if there is a certain organ receiving blood supply and no nerve supply, it is liable to get into a disease or a pathological process. For example, thyroid nodules which have blood supply but which do not have any more growth in a multinodular disease, 15 to 20% of them could actually be having malignancy. Same happens with the gallbladder. A non-functioning gallbladder is now a nidus for stone formation because of lack of mobility and poor function as far as the absorption and secretion are concerned. The same thing even happens to a diverticulum, and you can point out many other pathologies here, and keep in mind this even happens in a case of diabetic foot. There is blood supply, no nerve supply, and this is one cause of all the problems. What are the relative contraindications for any laparoscopic procedure, especially laparoscopic cholecystectomy? Ileus, peritonitis, diaphragmatic hernia, coagulopathy. Because in a case of ileus and peritonitis, there is hardly any space for you to create a pneumoperitoneum. In a diaphragmatic hernia, the more pneumoperitoneum you create, there is more compromise for the respiration. In a case of coagulopathy, you try a laparoscopic procedure and the patient bleeds. It may take you some time to actually go and open up the patient, which is maximum of 5 minutes, but there is a problem always of some kind of occult liver bleeding which you couldn't catch. In cases of cirrhosis, you are worried about the assimilation of the drug in the system, that is the anesthetic drug, its metabolism and even its excretion. Remember that when you talk about cirrhosis, you should talk about the Child-Pugh scoring. In gangrenous cholecystitis, it is best to do an open procedure as opposed to doing a laparoscopic procedure because the gallbladder is very friable. You may not be able to handle it completely, and even when you come to the stump of the gallbladder, you may not be able to do a good job. In case of multiple adhesions, you don't know where you're going. You may actually encounter troubles. You may even injure the CBD. Now remember that insufficient evidence does not justify the risk involved, especially in the elderly. I have written this statement directly quoted from the book because it is nowadays commonly believed that anybody having gallstones should get operated. But remember this, as we talked in the statistics earlier, only 15% of the elderly patients above 70 will come with recurrent attacks of gallstones or CBD stones after doing an ERCP. In a case of CBD stones with gallbladder stones. Second of all, just because somebody is young and you have the laparoscope available doesn't mean to say you should do a cholecystectomy without any clear indication. It doesn't make sense, although nowadays it's very cheap, very effective, and you can say it's a procedure having minimal complications. But you never know when something could go wrong and you could land up with some structural damage when you're trying to do a routine procedure. Pre-operative preparation begins with a good history and physical examination. Many times it happens on the OR table that the senior surgeon is called and he is told that this patient is having a POH or was previously operated for a cesarean section and now there may be an incisional hernia. So beware, in real life and yes, even in the exam, you should be able to take a good history and ask the patient about the current problem. When exactly did it start? Is the patient in an acute phase? And whether there is any past history, diabetes, hypertension, drugs, allergies, tuberculosis, bronchial asthma, varicose veins, because that affects you in your laparoscopic procedure. Remember, there is more risk of DVT then. Also, if the patient has had any past surgeries and taking any chronic medications. Don't forget to examine your patient's abdomen completely. Is it a virgin abdomen, any scars, any hernia? All this will affect you especially when you try to operate. Labs and coagulation profile is important because you don't want to take a patient who is having a poor liver function, and that will lead you to have complications with the metabolism of anesthesia drugs. Coagulation profile is essential because you don't want to have any occult liver bleeding or liver bleeding post-op. You need to do an ERCP before taking up a patient who is having CVD stones. Again, this relates to the metabolism of the anesthetic drug and its excretion in the bile. The patient is going for a general endotracheal anesthesia, so if they are obese, having a short neck, poor respiratory reserve, you need to ask the patient to have an incentive spirometer and to stop smoking in the likely event that they are smokers. The choice of antibiotic, usually you are going to hit the gallbladder, so target your antibiotics for the organisms expected in the biliary tree. But don't forget that you're also targeting the respiratory tract because the patient is getting anesthetized through the lungs and that you're exchanging cold gases inside the lung. So the lung is more liable for infection. So cefazolin usually hits both these tracts and everything is okay when you give cefazolin. Now apart from that, if you have had any biliary culture from the ERCP and you see that these organisms are not sensitive to your usual antibiotics, that's when you decide to change the antibiotics as opposed to going to an empirical therapy based on the hospital protocol. Once on the table, the patient is kept in the supine position, and please note that you are taking care the patient has passed urine prior to surgery. You don't want to hit a full bladder, do you? You're passing a nasogastric tube so that the stomach is completely emptied because at least in 20 to 30% of the time you encounter an inflated stomach. This usually happens when the anesthetist will try to intubate the patient, so pass an NGT and everything is okay. To prevent DVT, you're using drugs pre-operative. You're using prophylactic heparin or clexion, but you're also going to use a stocking because it's a mechanical effect to permit all the venous blood to prevent pooling in the lower limbs. The cautery pad should be placed cautiously because you don't want the path of current to be very close by to your cautery. Ensure that your table can accommodate a C-arm, that it doesn't have any metallic parts and most of the parts are radiolucent. Next issue is the suction and your instruments and the way the monitor and the anesthesia machine has been kept. Realize that the surgeon and the monitor are directly opposite each other. Usually in most cases even the assistant has a monitor next to them and there are two screens for the same laparoscopic camera. This is useful so that even your assistant knows what's happening as opposed to repeatedly telling your assistant or the nurse who is scrubbed with you, see, I'm in a very critical position and there is bleeding and I need this urgently. So if they are in constant view, they are also paying attention and they can mentally prepare what is required. Note that the anesthesiologist needs the longer tube so that he is not in the path, he is not in the way of you and your machine and you and your monitor. As far as the tubes are concerned, try to place all the tubes away from your operative field so that there is no constant interference of the tubes and your instruments. Because once this happens, mentally you try to adjust your hand position or the instrument position away from the tubes. That will make your wrists and forearms less ergonomic in position. Then you will end up with some chronic wrist pain. So remember that you will have to operate many patients, so don't put yourself at risk when you're operating. Keep the instrument tray or the Mayo stand far away initially when you position the patient, and once everything is done, that's when the Mayo stand comes closer. You're using your Mayo stand mainly as far as your opening and closing is concerned, so it shouldn't stay there all the while. So these are the things that you should take care well in advance. Certain points of time it may happen that the surgeon changes position after opening the patient and putting the ports or the camera, or when he does the first opening. When he turns over, make it a point that your cautery pads, your cautery pedals are kept close to your feet. It becomes very difficult when you're trying to look at the monitor, adjust your hand position and slowly try to take your feet away. This is not a Tom and Jerry cartoon where you're stretchable. Remember that certain structures can be pulled or too much of traction can be created on the gallbladder when you're trying to adjust the position of your feet. So after the patient has been prepped and draped, that's when you are to make the incision. Most surgeons prefer that the patient is being put in the Trendelenburg position. The reason for this is that all the bowel slowly moves upwards, and that the area of the pelvis and the lower abdomen is usually free of bowel. So when you tent up the abdominal wall and you drive the Veress needle pointing towards the pelvis, you may not tend to hit the bowel. But remember, this is not always true, because the bowel will be there regardless of whatever you try to do. A point to remember here is that when you're opening, people usually open in a subumbilical position. Don't open it supraumbilical, because you'll be hitting the falciform ligament, and there is a lot of length through which your trocar has to go. Rather, when I say trocar, actually I mean a cannula. The trocar is the sharp portion which is inside the cannula, and if it is not sharp, you call it an obturator. Usually we prefer a subumbilical position. Remember, don't go too low subumbilically, because you may hit the urachus or you may hit the urinary bladder in case it is full. There are some alternate sites where you can put your pneumoperitoneum. So take the umbilicus as the center point, and you can use the ninth costal cartilage tip upwards, or else you can take the midpoint of the spino-umbilical line downwards. These midpoints can be used to create a pneumoperitoneum, especially when your patient is having previous scars and in case you want to avoid the epigastric vessels. When you want to make the incision, you can either go in the open method or you can go in through the Veress needle method. So the subumbilical area is a good place to start. When you make the incision, remember that you should be absolutely perpendicular to the skin. Many a times people make an incision by keeping the blade slanted, or else they may not keep the skin straight. In the end, you will have a flap one over the other, and when you try to close the skin, you'll notice that it doesn't look cosmetically so nice. It also happens that people favor small incisions, and they make a 4mm incision trying to drive a 11mm cannula through it. What happens now is that the skin gets stretched, the epithelium gets torn, and it remains there for almost about 90 minutes to an hour and a half, to 2 hours, depending on how long your procedure takes. What happens now is that the skin gets necrosed. You can't see it immediately, but post-operative, when you come to examine your wound, you see some degree of necrosis, or maybe there is some blood clot below that. What's going to happen as a consequence is fibrosis of skin after death of the dermis, or you may land up with a wound infection. And you wonder to yourself why your infection rates get high. There is no breaking technique, but there is a very poor surgical technique. Just because you fail to make a 5 or 7mm incision, or you fail to make a 12mm incision. Remember, wounds heal sideways and not lengthwise. If it's a 100cm wound or a 1cm wound, both of them will heal in the same time. After having made the incision, you hold the skin with towel clips and you use an artery forceps or a mosquito to clear the fat so that you are directly visualizing the fascia. Once you do visualize the fascia, you can hold the fascia either on both sides or up and down with cockers or towel clips, whichever you prefer, and now elevate the parietes. The parietes is nothing but the abdominal wall. If you fail to elevate the parietes, it may so happen that you are very close to the bowel and you may tend to puncture it, although the Veress needle is blunted and it is very less likely that it may happen. Remember that the abdominal wall is normally around 5 centimeters away from the abdominal aorta. So when you elevate the parietes, you are increasing that distance, so it gives you some degree of safety margin. You are holding the Veress needle with a pen grip, and usually you may hear a double pop depending upon your speed. If you go really fast, that is the speed of sound, you may not even hear the click. If you go at the speed of light, you wouldn't know what has happened. And if you go very slow, the spring-loaded effect of the Veress needle may be so delicate that you may not hear a pop at all. So don't get too excited about the pop sounds. Do it at a normal speed as though you would give an intramuscular injection, and everything will be fine. Remember always to stay strictly in the midline. If you tend to go a little laterally, you may go through the intermuscular plane, so you may have some bleeding, and then the muscle tends to get into the Veress needle between the trocar and the cannula of the needle. When that happens, you may not hear any click at all. because of this muscle interposition between your instrument. So be a little careful and remember these tips when you are creating a pneumoperitoneum. In the likely event that you encounter some trouble, take off your needle and try again. And if you're really getting anxious about it, abandon the Verey's needle and go in for a Hassan technique, which is very safe. So you have heard two pop sounds and the Verey's needle is inside the peritoneal cavity. Remember that you are still tenting up the peritoneum with either your cocker or towel clips. The first thing you need to do is to aspirate. You could be in a blood vessel, you could be in the bowel, so let's see if something comes out. If you are aspirating and there is nothing coming out and you encounter negative pressure, either you are in the peritoneum or you are still extraperitoneal. Next thing you need to do is saline irrigation, and if you have a free flow of saline, usually you are inside the peritoneum because there is negative pressure in the peritoneum. A nice thing to do is the hanging drop method. Place a drop of water inside the lumen of the Verey's needle upper end and slowly lift up the parietes. If you see that the fluid goes down and the meniscus reduces, you know that you are in the peritoneum. If supposing you encounter difficulties as discussed earlier, convert to Hassan to save time and be safe. Now when you start the pneumoperitoneum, you need to connect the gas pipe to the Verey's needle. Start it at a low pressure of 5 to 7 millimeters of mercury and start at a low rate of 1 liter or 2 liters per minute. Let's do a little calculation here. 1 liter per minute means you're driving around 15 ml per second. Okay, so that's a very little amount of air. You're doing this because you don't want to suddenly increase the pressures, and sometimes the patient may have a vasovagal attack, although it is rare. It will take at least 200 ml of air for a man who is around 70 kilos in weight and around 5 feet 5 inches in length to get hyperresonance or loss of dullness in the right hypochondrium. It takes almost about 600 cc of air for a large built man who is around maybe 120 kilos in weight and 6 feet in length for you to achieve this hyperresonance in the right hypochondrium. So you do the calculation yourself as to how many seconds it will take for 600 ml of air to enter inside the peritoneal cavity. Therefore, don't check for hyperresonance very early as soon as you put the needle. You'll have to wait for a while, and once you get the hyperresonance, then you can increase the flow rate and also you can increase the pressure to 15 millimeters of mercury. It takes roughly 3 to 4 liters of air, that is basically carbon dioxide, to fill the peritoneal cavity. Keep a watch on your pressures and you see how you are going. There are 3 things which are there on your monitor. The amount of gas flow that has taken place from the time that you started the flow. Second of all, the actual set pressure. And third of all, the actual pressure inside the peritoneal cavity. If supposing you have a very little amount of gas which is flowing through and the set pressure, let us say, is 14 and the actual pressure inside is also 14, you need to think to yourself, why is it that the gas is not flowing? Maybe you're extraperitoneal. If supposing that your set pressure is 14 and the pressure which is showing to you, the actual pressure is either fluctuating up and down and the flow rate increases and decreases, you're in the bowel. If the flow rate is high and the actual pressure is very low and the set point is 14, you're probably in the vein, because the veins can take almost about 3.5 liters per minute, because the lung can excrete 3.5 liters of carbon dioxide per minute. So remember that it's a very high rate of exchange of gas of CO2 in the lungs. Therefore, if you're losing a lot of CO2 and you're not having any pneumoperitoneum, you're probably in the vein. It may also happen that your tube is kinked. This is very rare, so always check your stopcock and your tube when you're insufflating the air. This goes in not only for lap chole but all sorts of laparoscopic procedures. The patient is still in the Trendelenburg position, and you take off the Verey's needle and you insert the trocar and cannula towards the pelvis. Remember, at the same time you're also elevating the parietes. Some persons prefer to elevate the parietes, some don't, because once there is enough of air in the peritoneal cavity, it will tent up the peritoneum. The next thing you need to do is to confirm the entry into the peritoneum by the free flow of gas from the port. So open the stopcock, and if you have air, you know that you're good to go. Alternatively, you may even use a VisiPort by using the camera when you drive your cannula and trocar inside the peritoneal cavity. Once you're in, it's time to put the patient in supine position and then to place the other ports. And once all the ports are in place, that's when you turn to the laparoscopic cholecystectomy position by taking the patient head up, feet down, and tilting the table so that the right side is up. Remember here that when you're creating a pneumoperitoneum, there is air between the liver and the diaphragm, which pushes the liver down. And this point will become very important when you're doing your open cholecystectomy. If it wasn't possible to create a pneumoperitoneum with the Verey's needle, go in for the open technique, and the various sites that have been shown can be used. You need to make an incision in the skin and also in the fascia directly under vision so that you go through all the layers, ensuring that there is no bleeding taking place when you're doing so. Hemostasis needs to be achieved prior to going to the next step. Once the incision has been made and you reach up to the extraperitoneal space, that's when you take a stay suture on either sides of the incision, so that if you take your stay sutures and oppose them, the wound will be closed. It is almost like a purse string effect. Then go on to open up the peritoneum, place your finger inside the peritoneum and confirm that you're inside it. Then we move on to the next step. If your stay sutures are in place, you need to take the Hassan port and insert it with a screwing motion. It has threads, and these threads should fit inside the fascia or the parietes depending on your location. Use your stay sutures to secure your Hassan port so that it doesn't slip, and second of all, it always maintains the pneumoperitoneum. If there is any bleeding, you can use a fascia closure device to go on either sides of your incision and create a U-loop so that you can use it as a stay suture and also as a hemostatic suture. Once your trocar is in the abdomen and you have created the pneumoperitoneum, you need to white balance your camera and focus it. When you focus your camera, you should keep your target point of focus at least 10 to 15 centimeters away from your camera. Don't keep your focus point too close to the objective, and don't keep it too away from the objective. 10 to 15 centimeters is considered to be perfect. See to it that when you focus either a gauze piece or whatever material you're using, you're able to see each and every fiber under good vision and focus, and the camera has been white balanced already. Attach the gas pipe to your trocar, maintaining a pressure of 15 mm of mercury. Orient the video head and camera in case you are using a 30 degree or 45 degree scope. Then perform a general examination of the abdominal cavity, focusing on the area into which you entered, just to check if there was any counterpuncture of the intestine or a blood vessel. I have shown here on a table which I copied off from a very good website that there are different kinds of nerve fibers, the A fibers and the C fibers. A fibers are myelinated, divided into A alpha, beta and delta. C fibers are the non-myelinated fibers. The conduction velocity of the A alpha is just like a jet plane, whereas the A beta fibers are like a race car, let's say a Formula 1. The A delta fibers is the speed of cyclists, and the C fibers is like as though one is going for a slow walk. A delta and C, let's concentrate on these two. Both of them carry pain. Now when you insert or when you give the patient an anesthetic agent, infiltrating or inserting the anesthetic into the subcutaneous area, both nerves get blocked, A delta and the C fibers. Therefore, when you make the incision, the A delta fibers as it is have been knocked out, but the chronic pain which occurs and lasts for almost about 6 to 8 hours after the incision is also blocked because you're blocking the C fibers. This is the reason you're giving an anesthetic agent when you're making your incision over the port site. Remember, it is a standard practice and recommended and a good thing to do, and this prevents your patients from having pain, especially in the epigastric ports and other ports in the post-operative region. When you make your incision, the patient feels the pain from the A delta fiber, and the chronic pain is carried by the C fiber. So this is completely nullified when you're infiltrating anesthetic agents. This is a question which is asked many a times in the oral exam, and one also needs to tell this across the operating table to your juniors when you're infiltrating the anesthetic. Once the first port is inside, it's time to place the other ports. Usually, you need 3 5 mm ports and one 10 mm port. Some people prefer to have 2 5 mm ports and two 10 mm ports. It all depends upon the port that you put for your camera. You can use a 5 mm port because you have even a 5 mm camera. Now, the first port that you should place is the epigastric port. Usually you use a 10 mm port there because remember, your specimen has to come out from there. So it doesn't make any sense to make a very large incision initially. A 12 mm incision is good enough so that you don't damage your skin when you put in your trocar. Once your port goes inside, the next port that you need to place is the one which is at the fundus of the gallbladder. It is usually a 5 mm port put in the mid-clavicular line, maybe a centimeter or two below the costal margin, but usually most people prefer around 3 centimeters below the costal margin. The one in the epigastrium goes around 5 centimeters below the xiphoid. The lateral port is usually in the anterior axillary line and almost at the level of umbilicus. Again, it's preferable to go slightly superior and slightly medial, because if your instruments are 36 centimeters long and the patient is very obese, it becomes a little too difficult to give complete traction on the gallbladder upwards and laterally. Change the position of the patient from Trendelenburg to anti-Trendelenburg. Don't forget to infiltrate with the anesthetic agent because of the reasons already given earlier. Now remember that all your movements should correspond with the type of the trocar. There is no use of using a 5 mm camera into a 10 mm port using a reducer. Rather use a 5 mm trocar itself when you have a certain instrument. Once you're inside, you take the lateralmost port, put in a grasper, grasp the fundus of the gallbladder, and move the gallbladder upwards and laterally towards the right shoulder of the patient. Having done so, get your camera close by and try to visualize the junction of the neck and the cystic duct. Put in the Maryland from the epigastric port and take another grasper from the second port. Now triangulate both the instruments so that you are targeting a certain area. Start clearing off the peritoneum and the adhesions at the junction of the gallbladder and the cystic duct. Try to completely skeletonize this area and slowly move downwards. Now, if you want to start the dissection, you should grasp the peritoneum or the adhesions using only the tip of the forceps, give a burst of cautery, and then peel off the peritoneum and the adhesions in the opposite directions. If in the likely event that you have omentum, which is well vascularized, try to go to the adhesions because usually they are non-vascular. Proceed with your dissection starting from the junction of the gallbladder and the cystic duct. Keep going downwards till you have skeletonized a good portion of the cystic duct. Once you have done so, you have the peritoneum which is in between the cystic duct and the liver bed. Open up this area to completely skeletonize cystic duct and the blood vessel. Now if you can see the blood vessel hanging and on either sides you can see the liver bed, this is called the critical view. To get the critical view, your left-handed instrument or your left hand should give adequate traction on the infundibulum so that you are completely stretching it. Many a times when you grasp the infundibulum, remember that you are having the Hartmann's pouch, which is part of the pathology, and the Hartmann's pouch could be plastered to the cystic duct. So outwardly it could look continuous, But once you start the dissection and skeletonization, you'll realize that the Hartmann's pouch moves away, and you actually have more of cystic duct than you actually imagined earlier. So remember, it is important for you to dissect properly as opposed to doing a half-hearted dissection, and the danger of applying the clip on the Hartmann's pouch and the cystic duct together. If you do so, the Hartmann's pouch will necrose maybe in a few hours, and the clip will come off the cystic duct. Thereby, you will be landing in troubles, technical errors which lead to a bile leak. So therefore, realize you need a good traction laterally. Don't give too much of traction or else you will have CBD kinking. So there is a certain limit of traction to give. Everything is under vision, and remember that you don't have much of a tactile feedback. This slide demonstrates that the critical view has been obtained by complete skeletonization. You're going to put in your Marylands and open it completely. As explained earlier, that you have 17 mm of each blade, and when you open the blades completely, you have opened a gap of 17 mm. This helps you in two ways. Complete skeletonization will make it easier for your clip applicator to go there. You have enough spaces to keep the clips apart, and also you can gauge the size of the cystic duct when you're doing so by using the relationship of the teeth of the Marylands. This was told to you in the earlier slides. Clips are now applied to the cystic artery, and only then do you apply it to the cystic duct. The reason for doing this is because once you apply the clips to the cystic artery, the gallbladder has lost its vascularity. And in case you want to manipulate the gallbladder by doing either a cholangiogram on table, or if there is any more dissection of the gallbladder and there is a chance of bleeding, it is completely nullified because the vessel is completely cut off. So now you are dealing with a devascularized organ. It becomes less congested and everything is good to go. But remember that the time difference between you ligating your cystic artery and actually clipping your cystic duct is hardly anything. So in real life, it doesn't make a difference. It would help you only in case you need to do some more manipulation or else you need to do an on-table cholangiogram. If you need to do an on-table cholangiogram, you'll have to take off your left hand instrument, keeping your traction on the gallbladder steady. You grip the gallbladder using your right-handed instrument, or you put a grasper in the right hand instead of a Maryland. You need to take your instrument, which has at the tip a 14 gauge needle, through which you can pass a 4 French urethral catheter. Put it just proximal to your clip and pass the catheter through the cystic duct. Take off all the radio-opaque instruments away or align them away, and then you can shoot your X-ray. But remember that while doing a cholangiogram, you have to ensure that there are no air bubbles inside your syringe or even the tube. If there are air bubbles, they actually look like a filling defect and they can imitate a stone. How do you differentiate between a stone and an air bubble? Just simply change the position of the table. Air bubbles will change their position, but the stones remain static. If you have confirmed that there are no stones in the CBD, you can go ahead with the clipping of the cystic duct proximally, and then the only step that remains is taking off the gallbladder from the fossa. If there are stones in the CBD, you have two choices. Either to do an exploration of the CBD laparoscopically if you have the expertise, or else go in for an open CBD exploration if the stone is too large and you feel that there is no fun of doing it laparoscopically, or you can then refer the patient for an ERCP. There are questions asked to you as to the types of CBD stones post-op. Either it could be a retained stone or it could be a recurrent stone. So please see the earlier slides, video part 2, that gives you some degree of information of these phenomena. Take off the gallbladder from the fossa by retracting the gallbladder upwards and using an electrocautery in the loose areolar tissue between the gallbladder and its bed. At this point of time, you have to ensure that you don't bite into the gallbladder and at the same time you don't take a liver biopsy. Once the gallbladder is nearly finished up to the fundus, you can retract the gallbladder Check the bed for bleeding using the gallbladder as a traction, and you can even check the Calot's triangle for any bleeding, blood clots, or bile leak. If everything is clear, take off the gallbladder completely from the fundus. Now once your gallbladder is free, you need to retrieve the gallbladder in a specimen retrieval bag and get it out from your epigastric port. You can even enlarge or increase the size of the incision in case the specimen doesn't come out too easy. There is no use of playing tug of war for 5 minutes and at the end giving up and taking off the gallbladder by an enlarged incision. Rather do so first. Having done so, it's time to reverse the pneumoperitoneum, check for port site hemostasis, and you need to close your incisions. The epigastric incision is usually not closed because the liver will come back to that position and it will completely seal it off. Most people close the umbilical area because there is a chance of port site hernia from there. Best practice would be to close both the umbilical and epigastric ports because you never know which patient could herniate and which couldn't. Some surgeons, just before taking off all the ports, leave some saline into the peritoneal cavity. This is because they say that the saline will react with the CO2 to form carbonic acid. And this carbonic acid causes some degree of pain relief and it acts like a mild antiseptic agent. They even say that the amount of fluid inside the peritoneal cavity will go all the way to the right hypochondriac region, which is in the position below the diaphragm, and this prevents the shoulder tip pain which occurs as a degree of mild pneumoperitoneum. Remember that during lap chole you have retracted the liver and you have manipulated the gallbladder all the way up, and you will notice there is a lot of space created by the pneumoperitoneum between the liver and the diaphragm. This itself, if it's not completely drained, will lead to shoulder tip pain as a consequence of subdiaphragmatic irritation. One can do an open cholecystectomy with a CBD exploration as a pre-operative plan before, or else it could be happening that you're doing a lap chole and you need to convert this to an open procedure. In open chole, the patient is in the supine position, but it is always advisable to get the gallbladder into the wound as soon as possible. For this, you can use a bridge, the same kidney bridge which you have for renal procedures. You need to position your patient so that your bridge is positioned just below the costal margin. Now raise the bridge when the patient is in the supine position by about 4 or 5 inches. This ensures that the costal margin is elevated and that the liver and gallbladder are in a superior position. The parietes fall over the liver and the gallbladder, so when you incise, you will find that your gallbladder is just waiting to stick out. Also ensure that once your patient is in supine, you have kept enough foam pads to prevent pressure. You have kept a pneumatic compression device. Your ground pad of the electrocautery is correctly positioned, and that your table can easily permit the X-ray cassette in the likely event that you need an on-table cholangiogram. After prepping and draping the patient, you need to make the incision. The incision chosen is either a subcostal cocker incision or a midline incision. It is best to go in for a subcostal incision because it can be extended on either sides. It is less painful, it is better healing and a low chance of hernia. A midline incision on the other hand is more painful. As you know, upper abdominal incisions, they will create more atelectasis, more chances of hernia, and the exposure is not so good. You can't even lateralize the incision if required. Now you'll ask a question as to why you need to lateralize the incision. Let's imagine that there is some injury of the CBD and you need to do either a CBD exploration or a Choledochoduodenostomy. It's easier for you to handle it when you're having a cocker incision. Once the incision is made and the peritoneal cavity is opened, you need to insert your hand below the diaphragm, between the liver and the diaphragm, pull the liver so that there is some air under the liver. Then you can give good amount of traction on the gallbladder to get the gallbladder out of the wound and to expose the Calot's triangle completely. Had you put a bridge on the table below the patient, it would really help you in this step. And remember that there is air under the liver, so there are high chances that the patient would complain of post-operative pain or irritation on the shoulder tip, just as the lap chole. There is no difference. So you can use the same trick to take off all the air out, or you can infiltrate some lignocaine anesthetic below the diaphragm, just a spray just before closing the peritoneum. Some people even put a little saline for the same reason explained earlier. Give adequate traction on the fundus of the gallbladder and try to deliver the Calot's triangle into the wound. Definitely you are going to encounter adhesions, multiple flimsy ones, or sometimes even vascular adhesions from the omentum or from the gallbladder to the duodenum or the colon. You need to be a little careful here, as explained earlier, because the infundibulum could be really large. The infundibulum could be plastered to the cystic duct, and you will be dissecting very close by to the junction of the infundibulum and the cystic duct, thinking that it was the neck of the gallbladder. When you do so, remember you are dealing with a very short segment of cystic duct, and there is a high chance that you could be riding on the CVD. So you need to clear off these adhesions and clear off the peritoneum, skeletonize the cystic duct so that you are there in a safe zone. So for this you need to give adequate traction, because if your traction is inadequate, you may tend to lose sight of the structures. At this point in time, after trying to clear the adhesions in the Calot's triangle, you have one of two choices. Either do the classical open cholecystectomy, wherein you clear out the Calot's triangle, separate the vessels and the cystic duct, ligate both of them and divide them, and take off the gallbladder from the fossa. Or you can do the fundus first method, which involves separation of the gallbladder starting from the fundus, separating it off its fossa, giving traction, and then skeletonizing the cystic duct and the cystic artery. The disadvantage of the fundus first method, although it sounds easy, is that certain stones can slip from the gallbladder into the cystic duct into the CBD. Too much of traction can be put on the cystic artery, so it could actually start bleeding if it ruptures. Then the vessels could retract and difficult to handle them. It could also happen that the chronic inflammation would plaster the infundibulum to the cystic duct. Therefore, you get a wrong idea of the length of the cystic duct. It is preferable to go in the classical method. So palpate the infundibulum and the cystic duct, trying to find the difference between two of them. Place your artery forceps exactly on the infundibulum and then slowly dissect off that area. If supposing you find some difficulty, you can incise the hepatoduodenal ligament or the lesser omentum around that area, or you can even divide the peritoneum on either sides of the gallbladder so that you get some more mobility and you can visualize from inside outwards. Once the previous step has been performed, it's time to migrate your artery forceps and to rehold it at the junction of the cystic duct and the gallbladder neck. As explained earlier, you need to be a little careful there. Once you do so, you need to insert your right angle forceps so that you can completely skeletonize the cystic duct, and while doing so, create a space so that you can pass a double loop of ligature, one above and one below, keeping a distance of at least 4 to 5 millimeters between both of them, so that you can have a nice place to divide your cystic duct. Too many pictures here just to overemphasize the same fact that one should not give too much of traction while giving a dissection to this area. At the same time, you need to skeletonize the cystic duct adequately, because if you do so in a very small area, there is a chance that it could be the CBD. So for these two reasons, you need to be very careful at this step. It is one of the most critical steps of the open cholecystectomy. And remember that when you are doing it open, you don't have the advantage of a laparoscope and a magnified view. So be a little careful when you're doing this step. While ligating the cystic artery, also one should be careful that you're ligating only the single vessel. There is a chance that the right hepatic artery could be very close, giving a branch of the cystic artery. And when one is creating a lot of traction there, you could even cause a U-loop of the hepatic artery. If this does happen and you apply a ligature on the hepatic artery, the right liver would be losing its blood supply. And once the right side of the liver loses the blood supply, it's not a very nice consequence. So be a little extra careful at the Caros triangle while ligating both the cystic duct and the artery for reasons already explained. Once both the pedicles are dealt with, the only thing that remains is to dissect the gallbladder of the fossa. You can do so with a finger dissection because you can actually get the plane between the liver and the gallbladder. If it's a little too tough, you can use electrocautery, or you can even use a peanut which has been placed on an artery forceps. If you were planning to do an on-table cholangiogram during your open cholecystectomy procedure, because the next step that you were planning was a CBD exploration, you can put in your catheter into the cystic duct after you have tied off the distal ligature. You can use the distal ligature for traction, make a small incision in the cystic duct, and insert your catheter using a very fine non-tooth forceps. As usual, take the precaution that you don't have any air bubbles and inject your dye all the way and take the on-table cholangiogram. Differentiate between air bubbles and stones because stones don't move whereas the air bubbles do. Question: if you found CBD stones during an open cholecystectomy, what do you need to do? A simple answer: you need to either explore the CBD, take off the stones, or you can do an ERCP later. Now in the next few slides, we will be looking around to see how we do a CBD exploration. While starting the CBD exploration, you need to know the anatomy of the portal triad. The CBD is in front and to the right of the patient. The vessels are in front and to the left of the patient. And the portal vein is behind. It's quite a large structure. In cases of CBD stone, usually the CBD is distended, it's dilated, it's big. So don't be afraid thinking that you're going to explore a very thin CBD which is 6 mm in length. Usually it is not done. On encountering stones, you realize that the CBD is quite distended. One of the first things you need to do is to aspirate the bile duct and confirm that you're having bile. In case you get blood, you know that you're not in the CBD. Once you have confirmed that it is the CBD which is dilated, you need to clear off the peritoneum of the CBD over your incision. Don't skeletonize the CBD completely because then you'll be taking off its blood supply. Remember the 3 o'clock and 9 o'clock vessels we talked about initially. Then over the site of your proposed incision, which is going to be in the length of the CBD, not transversely, you need to put 2 statue sutures on either side. Then you make an incision, open the CBD. Usually stones will come out, and so does the bile under pressure. Have a suction there to completely take off all these things. And then you can either take a Desjardins forceps, or you can use a scoop, or you can put in a catheter and keep flushing out the CBD. Remember that your stones are mainly fat content, as we dealt with the chemistry of the stones before. And you also know that bile is almost 90% of water. So keeping this principle in mind, you'll realize that the stones in the CBD usually tend to float. This is the reason when the stones get impacted, they create obstructive jaundice, and slowly as the CBD proximally distends with bile, the stone gets disimpacted because it is light in weight because oil floats over water. So this is a physical principle which you remember while flushing the CBD with saline. Also another method is to take a very thin Fogarty catheter and pass it when you think that you have gone beyond the stone. Inflate the balloon of the Fugati and then give traction towards your opening of the CBD. This is very helpful in extracting stones, especially when you don't have a dischargence forceps. Once you have confirmed that the CBD is clear, you can take in a probe, insert the probe into the CBD, and see the probe coming near the duodenum. There was a sign called the Steele's sign. What you do is you insert the probe into the CBD and give a little lift over the duodenum. When there is blanching of the duodenum serosa, it means the Steele sign is positive. You'll also be able to palpate the olive tip of your probe over the duodenum. In the likely event of there being a big impacted stone at the ampulla, you may need to do a duodenotomy, a papillotomy, and to take off the impacted stone from there. If everything was clear and there was no stone, that's when you insert a T-tube. While inserting a T-tube, you need to cut a V section to prevent shouldering of the T-tube when you pull it out. If there was shouldering, then there will be definitely enlargement of your CBD closure, and that may lead to a bile leak maybe 14 days later when you do removal of the T-tube. These slides deal with the condition when you have an impacted stone in the ampulla. When you put in a probe, you feel a grating sensation and the Steele sign is negative. Here you need to cauterize the duodenum as shown. Insert your probe, ascertain the area, and then go ahead with doing a duodenotomy. Again, when you do a duodenotomy, do not make a transverse incision in the duodenum, but make an incision along the length of the duodenum. The duodenum has been opened, papillotomy has been done, and the stone has been then extracted. The tip of the bougie is then out through the papillotomy to confirm that there is no other stone which remains there. One can even flush saline twice or thrice from the upper end to see saline coming out from the ampulla. A T-tube after having been inserted in the CBD, sutures are put over the CBD, but remember that you are closing only one side. So you take your T-tube to either the upper end or the lower end and you put sutures only on one side. You don't want sutures to be there on either side of the T-tube. This is because one side is a naturally present tissue and the other side is going to heal. This closure that you do of the CBD does not have to be bile tight. Remember, even when you do a Choledochojunostomy or a Choledochoduodenostomy, you don't need a bile tight closure. That incision and that wound is going to heal by itself, and obviously it becomes bile tight in a few days. All that you need to do is to make a good connection. This is a special situation, especially in biliary anastomosis. You put a Jackson-Platt drain or another drain in the Rutherford-Morrison pouch, and then you go ahead by closing your incision. Remember here that your T-tube needs to be clearly marked and that your T-tube should have the shortest possible course through the peritoneal cavity. You don't want to keep a long and winding course because that is going to be the fibrous tract which develops after the removal of the T-tube. If the patient had chronic cholecystitis, a dilated CBD, chronic pancreatitis, too much of fibrosis around the head of the pancreas, and distortion of the CBD below the infraduodenal portion, that's when you decide to go in for a Choledochoduodenostomy. Because after the cholecystectomy, you want to ensure that there is a free flow of bile from the bile ducts into the duodenum. Proceed in the usual manner. You have done a cauterization of the duodenum. Now you have to make two incisions, one in the CBD and one in the duodenum. Both of these should be along the long axis of the organ. Therefore, you have an incision which runs vertically in the CBD and horizontally in the duodenum. The stay sutures which you had put on the CBD and the duodenum will then act as 4 points which are markers for you. The diamond shaped incision of the CBD should match the diamond shaped incision of the duodenum. When you close the incision, remember that the stay suture of the duodenum below will go to the angle of the CBD below, so that the transverse incision and the horizontal incision will match in a diamond shaped space as shown in the diagram below. It becomes too difficult to describe, but the diagram is self-explanatory. Remember that when you close the wound, the anastomosis does not have to be bile tight. It will heal in a few days' time, and up to 600 ml of bile leak on the first day is absolutely normal. The same stands good even for doing an open or a lap chole. If you have up to 600 ml of drainage on the first day, it is considered to be normal. Drainage more than that now needs to be reviewed, and you can think that maybe there is a bile leak somewhere. Or you can think of a biliary duct injury as discussed in the videos previously. The Strasbourg classification of biliary duct injuries has been explained along with each and every surgical procedure that you need to do as a solution to that. Once the wounds have been closed, a drain is left in situ and the main wound is closed. I need to re-emphasize that this anastomosis doesn't need to be bile tight. While doing a choledochoduodenostomy, you don't need to put in a T-tube. Yes, there are complications of patients who have had T-tube. I'm not talking about choledochoduodenostomy, but just T-tube closure of a CBD. Because on removal of a T-tube, there could be bacteremia, there could be a bile leak, there are more chances of having infection with the T-tube in situ, and people who are having a T-tube could lose fluid and electrolytes because of the chronic, acute biliary fistula during the time of the T-tube. Yes, there are methods to negate all these problems, but if you compare a person who is having CBD stones and you give him the choice, T-tube drainage after exploration or choledochoduodenostomy, it is better to go in for a T-tube drainage, take off the T-tube after 14 or 20 days, and then everything is back to normal, as opposed to doing a choledochoduodenostomy. Yes, in the long term, they have found that there are some changes of the gastric antrum and the mucosa because of the free bile reflux between the duodenum and the stomach. There hasn't been any more increased incidence of cancer rates. But one needs to keep this in mind because in the oral exam they'll ask you as to which is a better option, T-tube or choledochoduodenostomy, and you should be choosing a T-tube. In cases of chronic cholecystitis or a shrunken gallbladder, multiple gallbladder stones with a shrunken gallbladder, a very difficult anatomy, it is safer to do a subtotal cholecystectomy instead of trying to do a proper cholecystectomy and then probably land up with a CBD damage or damage to the vessels with the retraction of the vessels. When one does a subtotal cholecystectomy, keep in mind the pathology. The blood vessels inside the wall of the gallbladder are already facing constriction because of the fibrosis inside the wall of the gallbladder. Second of all, the manipulation that you do is good enough to devascularize most of the wall of the gallbladder. Then again, it depends on the amount of tissue of the gallbladder that you leave after the subtotal cholecystectomy. Studies have shown that if a subtotal cholecystectomy has been improperly performed, which means to say that you only take off the fundus of the gallbladder and you leave the remnant there is a chance of stone formation again. Therefore, the best possible thing to do is to do a proper cholecystectomy, as I shall be showing in the next slides. Proceed with the discussion as though you're going to do an open cholecystectomy. Come to the point of trying to expose the callous triangle. If there is no progress after a certain period of time, proceed with the fundus first method. Come to the area of the infundibulum of the gallbladder. There you need to dissect the gallbladder off its bed. Open the gallbladder, take off the stones, and try to empty the stones from the cystic duct also. Once having done so, you can close the gallbladder, and you have to cauterize the mucosa which is remaining over the gallbladder. And in case you did not peel the gallbladder off the gallbladder fossa, completely cauterize the mucosa. This is called the Lilly's procedure, because what he proposed was the mucosa is the one cause of all the pathology. If you take off the mucosa, there is no more trouble. After doing so and cauterizing the mucosa, you need to close the stump well. Once the stump is closed, the traction that you have applied, the dissection that you have done, and the purstring effect of the stump is good enough to shut off the minimal blood supply of the gallbladder. It will shrink off, the cystic duct will also lose its blood supply, and the only remaining thing is the CBD. But if supposing an improper procedure has been done, there is the problem of a retained stump, and this can later also collect a stone. So one needs to do a proper subtotal cholecystectomy when one embarks upon this procedure. In case of acalculous cholecystitis or empyema of the gallbladder, you need to do something quick to drain the abscess. If you don't do so, the patient could develop cholangitis, and later he could have all the other troubles as a complication of that. So remember, the cholecystostomy can be done as a bedside procedure under local anesthesia, or one can even do it in the OR. We are going to deal with the procedure which is done bedside, or it can even be done in the OR. The interventional radiology procedure can be discussed, or I think it has been discussed in the previous videos. After giving local anesthesia, one makes an incision in the subcostal area around the 9th costal cartilage, maybe around 2 centimeters below that. You will find the fundus of the gallbladder. Usually it is distended in the conditions for which tube cholecystostomy is indicated. A purse string suture is taken in the gallbladder, an opening is made, suction is applied, stones can be cleared if it's possible to do so. Put in a suction to completely deflate the gallbladder. It becomes easier for you to handle the gallbladder then. You may or may not take a next layer of purse string around the original purse string which you have taken. Put in the Foley's catheter, inflate it slightly, and then tie off the purse strings. While doing a tube cholecystostomy, take the precaution that your Foley's catheter is not in the same incision. So you need to insert the Foley's catheter into some area of the skin away from the main wound. While I was reading the atlas, I even saw choledocoplasty, which is usually done for a case of CBD stones or CBD strictures with stones. Usually the CBD is dilated. That's when you can make an incision which is vertical and then close it transversely. I read up the literature, and this is not a common procedure performed nowadays, because most people prefer to do a resection of that segment with end-to-end anastomosis if there is an adequate length of the CBD, or they may plan to either use endoscopic procedures like putting a stent or dilating the duct. If the stricture is too tight, there is no fun of trying to do an end-to-end anastomosis or a choledocoplasty, and studies have said that it's best to go for a Choledochoduodenostomy or a Hepaticojejunostomy. But since these slides were interesting, I thought I'd rather display them, because in the oral exam, if you're asked if you have heard of this procedure, you shouldn't say that you have never heard of it. Remember that surgical studies are not done by listening to things, you do it by reading books. You can take that as another tip. Choledochoduodenostomy is a procedure undertaken mainly by the hepaticobiliary surgeons. Although in extreme situations a general surgeon might be required to do this procedure. You need to know that in a case of obstructive jaundice, when the patient is having hydrohepatosis, hydronephrosis is when you block the ureters and the ureter and the kidney gets enlarged. The same name is given when the liver gets enlarged due to biliary stasis. It's called hydrohepatosis. It may also happen that the patient of obstructive jaundice is having cirrhosis, and a cirrhotic liver is usually firm, and it's a little bit more easier for you to take your sutures through. Even in sclerosing cholangitis, it is a very nice and firm liver for your suture to take a nice bite. Now the issue is that I've shown you the few slides. It's mainly to teach you the principle of the surgery. For better understanding of this procedure, it's best that you read a surgical atlas and then you go and watch one or two procedures with a hepatobiliary surgeon and discuss the same with him. The first step is the clearance of the lesser omentum or the hepaticoduodenal ligament, identifying the CBD, clearing of the CBD in the line of the proposed incision, or else clearing the CBD on either sides in case one is going to do a choledochoduodenostomy. Confirm the CBD is dilated by aspirating it, because you don't want to cut a structure and then realize it wasn't the CBD, but it was a portal vein. Haha. You need to insert a tube inside the resected portion of the or the stump of the bile duct. This tube usually comes out from the liver surface, and you take a stay suture around that. Create a rule limb that is in continuity with the common limb, and the NY or the Y limb will come for the hepaticojejunostomy. Then take the sutures from the jejunum directly onto the liver bed circumferentially, and the sutures are tightened. Meanwhile, you should ensure that the good length of the tube is inside the jejunum so that it acts as a stent when the mucosal healing takes place between the bile duct and the intestines. Thank you so much for watching the video. If you'd like to contribute any points, or you like to edit them, or you feel that something is amiss or should be updated, either leave your comments below or send me an email. Thanks again.